We are excited to introduce Dr. Melissa Deimling from Community Care Pediatrics Latham, located at 6 Wellness Way, right off Route 9 in Latham. Just so you know a bit about Dr. Deimling, if you don't already. She is a board-certified pediatrician, and she received her BS in neuroscience from the University of Rochester and her medical degree from Stony Brook. She then completed a pediatric residency at Duke University Medical Center, where she served as chief resident. She was on the faculty at the Duke Department of Pediatrics, where she practiced and also taught for 8 years before returning to the Capital Region in 2016 and joining CCP. Dr. Deimling is a fellow of the American Academy of Pediatrics, which really speaks to the standard of excellence she maintains for her patients. So we are very excited to have this session. Thank you, Dr. Deimling, for educating all of us today. And we are ready to get started. So with that, let me turn it over to Dr. Deimling.
Hi, everyone. Thank you so much for joining me tonight. I'm very excited to spend a little time with you as we prepare for baby. We've got lots to cover today, so I am just going to dive right into it, but I promise there will be time along the way for questions that you may have. I wanted to thank our community care team for working so closely with our group and putting this together for you all. We are really appreciative. Before we get to the learning, I want to get to the bragging. I am very proud of our group. We are Community Care Pediatrics Latham. We go by Latham Peds for short. We were very excited to welcome our patients to the brand new state-of-the-art facility, Wellness Way. Very conveniently located, great parking, lots to offer within the building, which I'll get into. We are a 9-provider practice. 3 nurse practitioners, 6 physicians. We are an all-female team. We are an all-mother team. We're all moms. So we know what it's like to be in your shoes. We love taking care of families, and we love welcoming new babies, and we are all accepting newborns. So we're excited to meet you. We are proud to be opened 6 days a week. Babies do not choose when they get sick, and it's often on weekends and holidays. So we are there every day but Sunday. We are in the office most holidays as well. We're really only closed 2 major holidays a year. We are always on call 24/7. So if you have needs at any time, we're there for you. Our building, besides having our office, we're kind of a one-stop shop. We've got lab right next door. We've got radiology down the hallway. We've got our very own pharmacy, ConnectRx, about 2 doors down from us. We've got a cafe. We've got it all right in one place. Our patients find that really convenient. And again, our building is new, it's big, it's airy, it's gorgeous. Our website has pictures of our office if you're interested in checking that out as you look for an office that meets your needs. Next slide, please. So the first 24 hours with baby can be really overwhelming. My goal for you today isn't necessarily that you're going to memorize every piece of information that I give you, but I hope that as you experience the first few days as a new parent, you're going to say, I remember Dr. Deimling went over a little bit about this, and just have some idea of what to expect. You have already gone through a big process of making a human being, delivering a human being, and here you are in your first few days as parents at that point. Lots to do, lots of people to meet, a lot of decision making, a lot of discussions about testings and screenings and procedures. So I want you to just be as prepared as you possibly can be. And then, of course, know that once the hospital experience is over, and we will review that in our other Baby Talk series as well, we're there for you to kind of take the experience from there. Next slide, please. This is our roadmap for today. Along each of these stops, there'll be a mini break for questions. We're going to move through pretty quickly. There's a lot to cover. So I do want to kind of keep it relatively broad. I'm sure there'll be lots of questions. We'll get into as much as we can. And as Alexis mentioned, there'll be time at the end for questions, and then you can always get in touch with us after tonight as well. Next slide, please. So let's start with feeding. Feeding is one of the only jobs that your newborn baby has besides sleeping and peeing and pooping. And that in itself, there's a lot of decision making that goes along with it. Basically 3 options: breastfeeding, formula feeding, or both. I'm going to get into a little bit of the pros and cons of each. So in terms of breastfeeding, there is no question that there is a lot of health benefit to breastfeeding, both in the immediate newborn period and later on in baby's life. We know from breastfeeding research that breastfeeding can reduce the risk of SIDS, which is sudden infant death syndrome. It can give moms antibodies, which are infection-fighting cells, over to baby. And later on, there's some studies to suggest it can reduce ear infection risk. It can reduce allergies, diabetes, and obesity. For moms, breastfeeding can also show some health benefits like reduction in certain cancers, high blood pressure, and diabetes. Breastfeeding is cheap. There's a caveat to that, but breastfeeding is cheap. Milk is free. The caveat is that certainly there's a lot of breastfeeding paraphernalia that goes along with it, pumps and nipple stuff, and all of that costs money. But over time, breastfeeding is probably more cost effective than formula. Breastfeeding in some ways is convenient. As long as mom's there, it's ready to go. There's no bottles. There's no need for water and powder. It's ready wherever you go. Breastfeeding has some cons for sure. It is not easy for a lot of moms to get breastfeeding started. I think there's a misperception that milk is in, latch is perfect, mom sits on her lily pad and breastfeeds and life is good. It's often not like that. Moms are exhausted, babies are hungry. Milk takes some time to kind of come in and reach full supply. It can be painful. Babies can have various latch problems. So it's not without its challenges. Luckily, our team, lactation team, the newborn team, there's lots of folks available to help you, but it can be a difficult start. It's also can be hard on mom just from an exhaustion standpoint. Babies want to feed every 1 to 4 hours around the clock. They don't care that it's daytime. They don't care it's nighttime. They want to feed, and mom's got the breasts. So that can be really tiring in the long run. There can be breastfeeding related complications like blocked milk ducts and infections like mastitis and fungal infections called yeast thrush infections. Those can be inconvenient, uncomfortable, and not fun for mom or for baby. And then there's some monitoring that may need to happen with moms, especially if they're on particular medications. There can be some dietary restrictions like excessive caffeine and excessive alcohol, which can be just sort of something else to have to think about. Next slide, please. Just like with breastfeeding, there's pros and cons with formula. Certainly formula doesn't have those same health benefits that are inherent to breastfeeding, like the passage of antibodies and some of those reductions in medical issues. But there's a lot of good to formula. It's ready to go. It's ready to go right away. There's no question whether baby is getting enough. You see how much baby is getting. So it takes the guesswork out of what we can experience with breastfeeding. It is easy for mom to get help from others since anyone can feed the baby a bottle. And it is in some ways convenient. You don't have to worry about having a place that's private or comfortable for mom. Babies can be fed anywhere. I think over the long run, formula can be more expensive between the bottles and the powders, the different nipples. It can add up over time, and it can be a little bit more time consuming. There's some prep work that goes into it, and there's some post work that goes into it between washing and sterilizing bottles. Next slide. The third option I mentioned is combo feeding, meaning you do a little bit of all of it. it is really hard to know what you're going to end up doing until baby is here. And we are here to kind of help you get on the feeding journey that you were hoping for and help you pivot if that journey isn't going in the direction we were hoping. Our priority is that baby is fed and that mom is happy and comfortable moving forward with the feeding plan. Next slide. I just wanted to take a minute to pause. Tell me if there's any specific questions that we can go over regarding feeding before we move on to the next.
We have one question, not about feeding, but about a process.
Sure.
What's the process of getting your newborn registered to be seen at Community Care Pediatrics Latham? Is there paperwork, et cetera, to do before their due date?
I see that. So step one, and we actually get into this a little bit at the end, and our website also has a great sort of your baby's here, how to work with us section as well. So check out our website. But essentially step one is the baby needs to be born first. We need a date of birth. We need a name. So you wait there. From the hospital is where you would give us a call to schedule that visit. It's usually within the first 1 or 2 days after discharge. And like we said, we're here almost every day. So we will get you in to be seen. It's a great question. Any other questions about feeding?
Nothing about feeding. Let me note, I didn't do this before. If anybody would like to comment, we can't see names or anything. Everything's anonymous. So please feel free and open to post any questions in that chat.
Next slide, please. So we'll talk about a few things that are going to happen sort of in the immediate period after baby's born in terms of treatments. Some of them are preventative. We'll get into everything. So basically in the delivery room, there are 2 treatments administered and strongly recommended for your baby. The first is the vitamin K injection. It's an injection, but it is not an immunization. It's just vitamin K. Vitamin K is an important vitamin that is part of blood clotting. Babies are born deficient in vitamin K. Without the ability to clot blood well, you are at an increased risk of bleeding. Important for babies to clot their blood, especially with the really, quite honestly, physically traumatic experience they've just been through being born. Without vitamin K, there's an increased risk of bleeding, especially into the brain. Baby's head is very, very vulnerable, and there can be really serious consequences to being vitamin K deficient and not being treated. Erythromycin, another preventative treatment. This is an eye ointment. It's the same eye ointment you may have gotten if you've ever been diagnosed with pink eye. Babies coming through mom's birth canal may be exposed to bacteria that can cause serious eye infections. So all babies are offered the erythromycin eye ointment, and it's obviously to prevent infection. These are both very low risk treatments. They've been done for decades, and I recommend both strongly. Next slide. The hepatitis B vaccine is the only vaccine that's offered in the newborn period. As I'm saying this, I will say that I wasn't thinking of this because it wasn't winter, when obviously not winter now, but I will say if you are planning to deliver towards the fall and winter time, there will be vaccination offered against the RSV virus. So my apologies for not having a slide on that. I'll have to add that for the next time. But besides the RSV vaccine, which by the way, I recommend strongly, incredible new vaccination that has significantly reduced RSV infections. It's been a game changer. So anyway, that will be offered it will be offered to moms in the RSV season this fall, and then maybe offered to babies if moms don't receive it. Anyway, hepatitis B, 3 to 4 part series, depending on the brand that your pediatric office uses. It is a required vaccine for New York State, so children must have that series completed. A lot of parents wonder, well, why am I giving hepatitis B in the newborn period? What's the risk there? Hepatitis B virus is transmitted through bodily fluids, and one way that babies can pick that up is directly from mom during the prenatal prenatal and birthing process. So this is a way to protect that potential transmission of hepatitis B to baby, and is recommended. Again, that is not a new vaccine, been done for decades, and definitely recommended. Next slide. Any questions about the treatments I've talked about here?
Not yet. I think we can continue on.
All right, next we are going to be talking about all the testing that may happen. A lot of the theme of the testing we do is that pediatricians are nervous Nellies, and we don't trust newborns to not be troublemakers. So a lot of this testing is often normal, but it is really designed to get ahead of serious potential issues that newborn babies can kind of find themselves in. One is blood sugars. This is a test where the heel of the baby is pricked, a small amount of blood is collected, and babies have their blood sugar or blood glucose tested. Some babies are eligible for this testing. Typically, if you are born small for gestational age, meaning smaller than we would have expected for your due date, larger than we would have expected for your due date, or if mom has diabetes, these babies are at risk for having low glucose or hypoglycemia when they come out, which can be dangerous. So those sugars are monitored to make sure that baby doesn't need any additional support. It is typically in the first 24 hours. Sometimes that can extend longer depending on what the results are. And it's usually about every 6 to 12 hours, depending on the situation. Next slide. Bilirubin. So this may be also known as yellow jaundice. This is something that is routinely checked in all babies at the 24-hour mark, sometimes earlier, sometimes later, depending on the scenario. It's definitely something that we in the sort of post-hospital outpatient pediatric office also follow very, very closely. Let me talk a little bit about what bilirubin is. So when babies are in mom's womb, their red blood cell count is higher than it needs to be than when baby comes out and starts breathing air. When baby starts coming out, doesn't need all those circulating red blood cells. The red blood cells break and they release a chemical called bilirubin. Bilirubin circulates in the bloodstream and sort of causes that yellow color. Most babies are a little bit yellow or jaundice. What we're looking for, and we even know down to the hour old that a baby is, we're looking for the babies who may have levels that are above what we're comfortable with. Babies who are at higher risk of that high bilirubin level are babies who are born a little earlier, at least 3 or more weeks before their due date. Believe it or not, mom's blood type matters versus baby's blood type. So if there's some differences between mom's blood type and baby's blood type, that can increase our worry about bilirubin. And babies of Asian descent, that in itself is a risk factor for having elevated bilirubin. So it's something that's monitored. You may hear doctors talk about this number. They may tell you that the pediatrician should check it as well. We always get that information from the hospital, so all of that's communicated. And if when you leave the hospital that number's at a level that's a little bit higher than they want, I would want you to expect your pediatrician to be monitoring that. Next slide, please. So this is a picture of a baby at a tanning bed. No, just kidding. So when babies have elevated bilirubins beyond the number that we're comfortable with, and this is an infrequent thing, but something I just want to talk through. Unfortunately, sometimes babies will need to go back to the hospital for a day or two to go under what's called phototherapy. It's this blue light that helps bring that bilirubin level down. It also helps to do lots of feeding. Babies get rid of their bilirubin by peeing and pooping, but this is what to expect if babies need to go back to the hospital. This is rare, but it is something that can happen and something we're really looking out for. Elevated bilirubins can be dangerous. They can affect babies' brain development, cause developmental issues in the future. So it's the reason why we are such nervous Nellies about bilirubin. Next slide, please. So the New York State newborn screen will also be checked at around 24 hours for baby. This is a test that actually looks at a lot of very rare diseases. The purpose is to pick up on diseases that are something we want to know about as soon as possible, but not something that would be very evident in a newborn baby just by looking or examining them. Every state has their own newborn screen. Every state has a lab that performs these tests. And ours happens to be fantastic and check for a lot of really rare things and can pick up on things before we would have even known about them. We typically can review these results with you around 2 to 4 weeks of age. If there is an abnormal test, we are typically notified sooner and we reach right out to the family. I will say again, this is a rare occurrence, but something that is important and absolutely something we recommend. Next slide, please. Group B strep. This may also go by GBS if you've heard that. This is one of those things that for mom, not that big of a deal, but for baby can be a big deal. Moms are typically screened for group B strep with a vaginal and rectal swab towards the end of pregnancy, around 36 weeks or so. And if your group B strep status is positive, meaning you carry that bacteria, you can expect to be given antibiotics during your delivery, and that will sort of prevent the transmission of group B strep to baby. The reason we worry about GBS or group B strep in babies is it can cause serious infections, urine infections, blood infections, and meningitis, which is a brain and spinal cord infection. So we want to get ahead of that by treating mom during the labor and delivery process. After baby is born, depending on the circumstance, baby may also undergo some additional testing to rule out infection if they are born to a mom with GBS. Next slide, please. All right, I know that's a lot of medical stuff, and I know it's a lot of here's all the scary stuff that can really hurt your baby. So again, these are rare things that we are looking out for. I know it can feel overwhelming, but I did want to go over it all. Tell me what questions you have about all of that.
I don't see anything just yet in the chat. Let me just refresh to make sure. And again, anything that we missed at these segments, I know. Anything we missed at these segments.
Don't be shy, everyone. Don't be shy.
We'll catch it at the end, but please, yeah, write your thoughts, questions, comments, concerns.
Maybe it is good that everyone's anonymous. They can ask any question they want under the cloak of anonymity. All right, well, if no questions, let's move on. All righty. So we're going to be talking about some testing your baby. We'll go through that is not blood work. So the APGAR system, scoring system, this is sort of baby's first performance review at 1 minute of life. This is not that important in the grand scheme of things. For the delivery team, it's an important way to communicate how baby is doing, but doesn't typically have any bearing on the successful life that your baby will lead. So it is a way within the first minute and then 5 minutes of baby's life, so right as they come out of the womb, to give us an idea of how baby's transitioning. It's a big change to go from inside a womb, being fed by an umbilical cord, not having to breathe, to come out here. We are looking at things like how the baby is moving, how's their color, how's their breathing, how's their heart rate, and we assign babies a number. 10 is the best, but I'll tell you, nobody gets a 10. 9 is typically your high score. And I'd say 7, 8, and 9 are great scores at 1 minute. And then there's another score given at 5 minutes. If babies are still having on the lower end of scoring, they will get another score after some observation and usually some interventions like drying them off and patting them and sucking out their nose and all of that. And see how they're feeling at 10 minutes. For babies who are still struggling with that transition, sometimes there is some observation period at the NICU. But again, the APGAR score is not that big of a deal other than those first few minutes to see how baby's feeling. But you may hear people call out a number like 7 or 8 or 9 when you're in the delivery setting. Next slide. All right, the hearing screen. So This is very similar to the New York State newborn screen in that it is very difficult to assess a baby for hearing loss in the newborn period, but it's important to know about it as soon as we can. The hearing screen is a very non-invasive test that's recommended for all babies before discharge. And it is exactly as it states. So they'll wear little headphones and it'll be able to see how the eardrum responds to sound waves. Sometimes babies may have trouble on one side or the other. They call that a failing score. That is typically not as a big deal, not as big of a deal as it seems. When babies are in utero, they're in a lot of fluid. When they come out, there's still a lot of fluid in their ears. So it's very common for babies to need a little bit of extra time to get all that fluid out and repeat that test. And oftentimes, and they do fine on the repeat. And we usually repeat it a few weeks later and move on, because there's really not, if that is normal, we can feel very confident that baby's absolutely fine. Next slide. The congenital heart disease screen, you may hear it named the oxygen screen or the heart screen. This is an oxygen monitor that is placed on baby's hand and foot. And what we are looking for is any issue with the structure of the heart that may impact the way baby is oxygenating their blood. It is a quick test. It takes a minute, but it is an important one to make sure that we're comfortable with baby's heart function. Next slide. All right, circumcision is, I guess if you know you're having a girl, you can kind of tune out for a bit, but very controversial topic. A lot of decision making goes into this. I wanted to just review the pros and cons of circumcision. I can skip to the last chapter of this discussion and tell you that the AAP, the American Academy of Pediatrics, kind of says it's a toss-up. You decide as parents what you would like to do. So they really don't come down on one side or the other when it comes to whether or not you can circumcise. Let's go through the good stuff. So the compelling reasons for me are the reduction in STDs and the reduction in UTIs or urinary tract infections. Now, those are rare in general, but we know that circumcised babies do have a lower risk of that. The other risk reduction is in genital cancer, super rare. So you're sort of reducing the risk of something that's rare to something that's even rarer, but something I think that is notable. It can be easier to clean a circumcised penis. Conformity, and you'll see this kind of on both sides of the coin, depending on like regional trends, your family's trends, sort of having babies' penis look the same as everyone else's as they grow might be something that's important to you. And then certainly circumcision can be dictated as part of religious or cultural practices. The downsides of circumcision. So certainly there's pain. It is a procedure. There is a local anesthetic given to reduce pain, but it can be a painful procedure. It's quick, but there can be pain associated. Complications are rare, but they do happen. Typically, they are cosmetic, meaning not enough skin has been taken off, too much skin has been taken off. One we see frequently is the circumcised skin tends to, over time, readhere or regrow onto the penis, the head of the penis. In the immediate procedural time, there can be bleeding. I have to this day not seen a circumcision infection, but it's certainly a potential complication. But this is typically offered in the newborn period. And locally, this is usually done by your OB team. Next slide, please. All right, questions about what we've talked about there?
We do have two questions. Going back to group B strep, what about group B strep positive, but a C-section birth?
Yeah, so that, let me just see if I can refresh to see the questions. I'm a visual learner. Can you say that again, Alexis? I'm sorry.
Yeah, of course. What about group B strep positive, but a C-section birth? It was a fleeting comment in the chat, but I
so great question. So the one circumstance, and I always say I'm not an OB, but one circumstance that a baby or a mom may not need to receive antibiotics is if this is a scheduled C-section that has no labor. If mom has labored and baby has come into the birth canal as part of that process, antibiotics would be indicated.
Okay. If it's required to give antibiotics during birth, is it recommended to give the baby probiotics to restore healthy gut bacteria?
Yeah, that's a great question. So the antibiotics go to mom. They don't go to the baby. We don't routinely recommend probiotics in the immediate newborn period for this reason. And then the heart testing, that's a great question. So what we are looking for with the congenital heart screen is the type of heart defect that would impact your body's ability to oxygenate blood correctly. A bicuspid aortic valve would not be one of those things. So no, the congenital heart screen would not pick up a bicuspid aortic valve. We've got our handy stethoscopes, which help, and often valve issues in babies may be even picked up prenatally. On your anatomy scan. But no, what we're looking for is heart disease that would cause oxygen levels to be lower. These would be things that we would want to know about immediately and typically require repair in the newborn period. Luckily, a bicuspid aortic valve is not one of those things. Any other questions?
No, we may continue.
Sweet. Let us proceed. All right, so we're going to just talk about some weird stuff that you may have read about, but oftentimes you don't, but every baby seems to do and causes us to freak out a little bit. Go ahead and go to the next slide. I probably have some pictures. Yeah. So the first is molding. Babies are in this tiny little studio apartment in the womb, and they got to go through a really tiny tunnel, and they can get a little banged up on the way out. And that includes their heads, which are kind of like a lump of clay, getting squished on the way out or getting squished as they're positioned in the womb. So babies may come out with like a cone head or a shifty head. Luckily, babies' skulls are not fused. So they're actually pieces of bone that are not yet all together, like kind of like tectonic plates. And that allows, as the baby's brain grows, as the head size grows, that allows sort of that pop-off valve for the brain to have some room to grow. And therefore, as the brain grows, the head definitely rounds out quite considerably. For babies whose heads look like this in the picture, usually within the first few weeks, it's perfect. Just take some time. Next slide, please. So also part of that birth process, babies can come out with this kind of squishy bump or horn on their head. It's usually one-sided, but it can be both sides. And it's called a caput or a cephalohematoma. I won't bore you with the difference between them, but essentially it is a collection of blood and fluid under the scalp. Usually from getting stuck or needing, for example, to be pulled out with the assistance of a vacuum. It goes away with time. It takes a couple of weeks usually, just needs monitoring, but there's no interventions that are needed. Next slide. Many babies will have this blue birthmark, typically on their bottoms or their lower back, but it can be anywhere. It's called dermal melanocytosis. I don't know how well the pictures come through for you, but it looks blue. And for some families, it can be mistaken for bruising. It is not bruising. And it is nothing to be worried about. With time, it does fade away, but a very common spot that you may see on your baby. Next. Purple hands and feet. And I will also add purple rings around the mouth are really common too. This is called acrocyanosis. When babies are born, their circulatory system isn't fantastic. It's going to prioritize the center of the body, getting great blood flow to the brain and the belly, and obviously the heart and lungs. And the hands and feet sometimes don't get as good a flow. So those hands and feet can look really purple. They can feel very cold. Same with around the mouth. It can last a few weeks. It's especially noted when babies are like not swaddled or they're coming out of a bathtub. And it's nothing to be concerned about. It doesn't mean there's an issue with your baby's heart or that you're not doing a good job keeping your baby warm. It's just the way that their hands and feet look for the first few weeks. Next slide. So some spots that your baby can have other than the blue spots we mentioned. The medical term is nevus flammeus. My grandma would call them a stork bite or an angel's kiss. And they're little spots that can happen like between the eyebrows or on the eyelids or the back of the neck. They are very genetic. So you may look at your own baby pictures or your partner's baby pictures and say, oh, you had those. They fade with time. They don't cause any problems, but they can make parents worry. Don't worry about them. Next slide. So this is called a subjunctival hemorrhage. It may be called a subscleral hemorrhage. Essentially, going back to the traumatic birth, these babies go through a lot to get here. As part of that squeeze, they can essentially break blood vessels in the whites of the eyes, and they'll get this kind of red mark along the iris or the colored part of the eye. This is not bothersome to them. It is not concerning for their vision or their eye development, and it will fade usually by about a month. Those spots are gone. Nothing to do about them. Slide. So what this picture is showing is white firm dots. We call them Epstein pearls at the roof of the mouth. They can be mistaken for thrush, which is a yeast infection of the mouth. They can be mistaken for like my baby's growing teeth out of weird spots. These are benign, meaning not worrisome, small white dots that will fade with time. They don't cause any problems with feeding. They're not painful. And there's nothing to do about them, but they're there. Next. So tongue-tied medical term is ankylosing. This, continues to be a really hot topic in pediatrics, in lactation, and, something that I think a lot of my newborn families ask me about. So if you can see the picture well, you might see a little flap of skin under the baby's tongue. We all have a flap of skin under our tongue, and thank goodness we do. Otherwise, our tongue would kind of wag around like a horse. But there are some babies when they're born that flap of skin is just attached a little too close to the front of the tongue. You can imagine if you've got that kind of flap attached to the front of your tongue, it makes it harder to stick your tongue all the way out, and it makes it harder to put your tongue up. Those two movements are needed in order to latch to a breast, latch to a bottle, baby's only job, right? And so some babies are eligible depending on how they're doing with their feeding function. They may be eligible to have that area removed or cut. It is a procedure. So it's something that we really only recommend for babies who are struggling with their feeding, or especially if mom is also struggling with the breastfeeding and we think that the tongue is related. The upper flap of skin, and you can look at yours whenever you want. We all have a flap of skin that connects our upper lip to our upper gum line. That typically, from our pediatric standpoint, isn't usually something that we think causes clinical concern. Even if it's a little bit thicker or attached a little bit lower, especially if babies are feeding well. And we don't typically feel that alone requires immediate intervention. But this all depends on so many factors. It's important to see how baby's feeding and growing and see how mom is feeling if she is breastfeeding. Typically, we recommend seeing a specialist called a pediatric ENT or otolaryngologist. There are also pediatric dental teams that will evaluate and treat babies who we have a concern has a tongue tie that may be impacting feeding. Next slide, please. Any questions about what we've talked about and weird stuff babies do?
I don't see anything yet.
We can move on if you'd like.
Yeah, I think we can move on.
Sure. All right, so just a couple of weird things babies do. And I will say we're gonna have a whole talk about sort of reasons you should call us, reasons you shouldn't call. I mean, you can always call us, but reasons that you don't have to call us. And probably some of this will be reviewed in greater detail. So I'm just going to touch on this quickly. First is the startle reflex. So baby's neurologic system is pretty immature at first, and they do a lot of shaking that freaks out new parents, of course. The startle reflex is essentially when babies are moved, there's a sound, they're unswaddled, they'll kind of do this little brief shake of their arms, of their legs. It is not usually and shouldn't be associated with them acting differently in any way, and it stops on its own within a second. But it's something to look out for. Hiccups. Hiccups are very common in the first few weeks, even months. Babies are chugging. They're chugging for 20, 25 minutes every time they feed. Of course, they're going to have hiccups. It is not a reflection of how your feeding is or whether you're doing a good job with burping or anything. They happen. And there's not a lot to do to stop them. They come and they go. They're a little bit of a spasm of the diaphragm, which is that big muscle that helps your lungs expand. So nothing to worry about, but something that's very common. Man, babies do a lot of sneezing. That in utero environment is just fluid. They're inside a water bath, a fluid bath, an amniotic fluid bath. When they come out, a lot of that fluid's still stuck back of the nose, back of the throat. They spend the first couple of days doing a lot of sneezing. They're just trying to get all of that out. No, they're not usually sick. No, they don't have allergies. And no, this isn't your pet, for example. They are just doing the body's natural job of getting everything up and out. Spitting up is common. Spitting up birth fluids at first. At another talk, we'll talk about spitting up like milk, which is super common, but babies are just like the sneezing, trying to get all that birth fluid up. So you may see like a clear or a mucusy kind of spit up that comes up with babies after they're feeding, especially in that first day or two. Sleepiness. Babies in the newborn period sleep a lot. They kind of trick you into thinking it's going to be this easy for a little bit. They usually wake up around 3 or 4 weeks, but first couple of weeks, man, they sleep a lot, maybe 21 to 22 hours in a day. They're basically sleeping, eating, sleeping, eating. So much so that we sometimes need to wake them up to feed them if it's been a while. And that, that depends on a lot of factors, but being born is hard for babies, so they do spend a lot of time being sleepy. Certainly if babies are so sleepy that they're missing more than one feed, or some other issues that we can certainly talk about in the pediatric visit, those would be more concerning. But essentially being sleepy enough to sleep in between feeds, but being able to wake up and feed when it's time isn't concerning at all. Next slide, please. Okay, so we made it. We again want to just direct you to our website. Again, all our providers are taking new newborn patients. Our biographies are all there. If you'd like to learn about us, you can flip through all of, sort of the way our office works, policies. There's a photo tour there. Forms are there for registration, but you're not going to do that yet because we have to wait for baby to be born and have a date of birth. It also reviews insurance. And next slide, please. I think we went over that, sort of what to do after baby is born and how to schedule with us after discharge. Next slide. And I wanted to plug my colleague, Dr. Latham and Allie's talk next week. She will be going through infant sleep, which is a very important topic. So please do mark your calendars for that talk. Next slide. So what other questions can I answer? And this can be about really anything.
We do have a question. What's the one thing you wish all new parents knew before leaving the hospital?
I think I wish all parents just knew that they're doing a great job. It is inevitable to go home feeling like you are doing this the worst out of everybody. It's chaotic. You have no idea what you're doing. You've just met someone that you love more than you could ever think you could love, and you're exhausted. And usually parents in the first few days are just feeling like this is not going the way that I thought. So I wish parents knew that they were doing a great job, and that they should listen to the people that they trust to guide them through this process. And to give, I wish that parents would know to give themselves a lot of grace in that they're learning new skills, their baby is learning new skills, and that everything's going to be okay. Other questions?
I don't see anything new just yet, but let's give it 30 seconds or so. If anybody has any
Sure.
remaining questions, thoughts, feel free to drop it in there. Okay, here's one. I've heard babies lose weight before going home. How much is normal?
Yeah, so that is true. Babies, almost all babies do lose weight. They're born probably with a little extra fluid on board. And we know, especially for breastfed babies, the milk's not in yet for a few days. So typically babies do lose weight, and that's expected. That's sort of normal and natural, and what we're used to seeing. We talk about weight loss in terms of percentage below birth weight. And up to about 10% loss of your original birth weight for us doesn't give us a lot of pause. And babies actually get up to 2 weeks to come back to birth weight. So it can be kind of a slow march back up to birth weight. We see our newborns pretty frequently in the first couple of weeks to check in, and see how things are going, and make sure we're sort of achieving that goal, the march back to birth weight.
Thank you. Can you talk about the pros and cons between vitamin K injection versus oral drops?
Sure. Oral vitamin K is not even close to as biologically available as injection. And also, giving vitamin K is a time-sensitive treatment. Ideally, vitamin K is administered really within the first 6 hours. And what's available, again, as part of just standard newborn care is the vitamin K injection. That's going to be the way to get it to the sort of get it delivered and metabolized by the baby in the best way to prevent complications.
Okay, the next question is, should I limit the number of visitors in the hospital with a newborn?
Yeah, so I mean, what I would say is first wait and see what the hospital policy is, depending on what's happening in the community. Sometimes the hospital does that for you. My recommendation, again, I talked about how this can be kind of an overwhelming and really chaotic experience, is to keep it pretty small at first. There is so much time for family and friends to meet baby. And I really think the first few days are about kind of hunkering down and figuring out this new life that you have. So I would be really thoughtful about those you think can provide you with a lot of support in that period. I certainly would want any folks who are meeting the baby either in the hospital or at home to be feeling well. But I think I always recommend, especially in that first day or two, just keep it small, let yourself get settled at home, and then you can kind of start having people come by. But ultimately, as with everything, this is entirely your call and your comfort level.
Can you please recap what is the process for community care referral after birth?
Sure. Yeah, let's go over that again. So have your baby. That's step one. Give us a call after that point, because we need a date of birth. We need a name. We are there. We're in the office available to see newborns 6 days a week, so every day but Sunday. And typically just give us a call to schedule. That's going to be usually done before you're discharged from the hospital. And we recommend babies seen within the first few days after discharge to check in.
What are the pros and cons of waiting on the Hep B vaccine?
Yeah, so Hep B is, I look at it kind of in the same realm in terms of time sensitive as the vitamin K. We want to get that protection mounted as soon as we can, because again, what we're trying to prevent is a perinatal or mom to baby infection. So we do recommend getting the hepatitis B in the hospital, which is the typical protocol. However, we also do offer the hepatitis B vaccine in the office. Other questions?
A few more questions. What
Sure.
vaccines should parents, such as dad, and grandparents get before being around a newborn baby?
Yeah, so this is also probably a little bit seasonal, but I do recommend flu vaccine for anyone who is going to be spending pretty, direct time in contact with baby. I would like adults to be up to date on their Tdap vaccine. The P in Tdap stands for pertussis, which is definitely here in the community. Adults should be vaccinated with Tdap ideally every 10 years. And then of course, like their regular like childhood vaccines as well.
Is it true that babies that are breastfed should supplement with vitamin D?
Yeah, so not something that I want you to worry about in the newborn period. Again, we're going to talk about this at another talk as well as we get into like what happens when you come home with the baby. But I love that you're thinking ahead. So yes, babies who are breastfed should receive additional vitamin D, which is just an oral supplement that's easy to find at the pharmacy. It's like a daily drop or dropper full. I typically review this around 1 or 2 weeks of age when everyone's kind of settled down a little bit and the baby's on a roll. We would talk about that. But yes, breastfed babies or predominantly breastfed babies, whether it be at the breast or via pumped milk, should receive additional vitamin D. That is added to formula. So it's not something formula fed babies need to worry about.
I love this. We have a few more questions. What are
Great.
the risks of kissing a newborn, especially around the face or hands?
Yeah. I worry more about the face than I do about the hands, although babies do spend a lot of time with their hands in their mouth. Babies' immune systems aren't fantastic. They're not vaccinated. Their immune systems are very immature, so they are at higher risk of infections. And so essentially that's the biggest risk is the transmission of potential infection. So I don't recommend people come in mouth contact with babies, faces or hands. If they must come in contact, they can give the baby's feet, I guess, a little smoochy. I know sometimes it's just unavoidable, but the preference is to kind of not leave newborn babies alone without that direct contact.
Okay, let's go back to some vaccine stuff. Should dads also get the RSV vaccine? I understand for moms, it allows the transfer of antibodies, but is it helpful to prevent dads from potentially getting babies sick?
Mhm. So I don't take care of adults and I don't take care of pregnant ladies. So I am probably not going. Here's what I know about that vaccine. I believe it is only you are only eligible for it if you are a pregnant woman or if you are elderly. So if you are sort of a healthy, non-elderly male, you are not eligible for the RSV vaccine, at least what I know in the here and now.
Okay. What if you're already negative for Hep B? Is there still a risk with delaying the vaccine?
Yeah, so I think that you never know when you're gonna come in contact with hepatitis B. We talked about babies getting a lot of blood sticks in the hospital, for example, and that there's a risk with any sort of like medical procedures of transmission of hepatitis B from other sources. Certainly, these are all very small risk, very theoretical risks, and moms are tested for Hep B early in pregnancy. One thing we wonder about is transmission of Hep B later in pregnancy when it's not retested. Um, Hepatitis B is a really well tolerated, low risk vaccination, and so I think that the potential benefits outweigh any downside, whether it be in the newborn period, or excuse me, in the newborn hospital or shortly thereafter.
Okay, I think we're doing okay with questions. Let me refresh here. I know there's a
Sure.
couple seconds of delay, so we'll give it a minute. Great questions, though.
Yeah, they are. I agree.
I don't see anything. And again, if we missed any questions or that, there's too much of a delay and we don't catch it before we end, you can reach out to marketing@communitycare.com, or of course you can reach Dr. Deimling and team at Latham Pediatrics directly. I think we are in good shape.
Great. Thank you again, everyone, for taking this time to hang with me and learn a little bit. I wanted to plug my colleagues. I mentioned Dr. Latin and Allie's talk coming up in about a week and a half. But there's more coming up after that. I will be doing episode 3, which is sort of what to expect post-discharge. Dr. O'Connor will be doing a sort of when to call the pediatricians, what's normal and what's not kind of review, which I think will be fantastic. And a few of our nurse practitioners who are former NICU nurses, so a lot of time spent taking care of preterm babies, they will be doing a fantastic talk about caring for the premature and the late preterm infants, which is something that we commonly see. So we hope you can join us.
Dr. Deimling, we have
Yes,
one
ma'am.
remaining question, if you can do it in 2 minutes. Do you have any resources for breastfeeding moms within the first few days after you get home from the hospital?
Yeah, so actually you will work with the lactation folks at your birthing hospital, and they are actually typically our best resource, and they will also give you a list of contacts as well that are even outside of the birthing hospital. There are several terrific community groups that we recommend, as well as the lactation consultants in the newborn hospital.
Okay, I think that officially concludes the questions.
All right, cool. Thank you, everyone. We appreciate you.